Hello, my name is Dr. Linda Mabula Schufelt, and I will be speaking about public health and missions today. A little bit about myself: I went to medical school at UCSF and did my residency in internal medicine at Johns Hopkins Bayview. I then deployed to Haiti with Samaritan's Purse, where I worked as a medical director for a year at a small clinic called Cité Soleil. I then moved back to Baltimore, did my master's in public health and postdoc at Johns Hopkins. I'm going to talk a little bit about a couple of experiences I've had working in public health, but also doing missions, primarily with Samaritan's Purse. How did I first of all get involved in missions? In January 2010, a 7.0 magnitude earthquake struck Haiti. And Haiti was quite devastated by this earthquake and is still dealing with the aftermath. And when I saw the images of the earthquake on television, I was quite moved and really wanted to go to Haiti to help using my skill set. During that time, I was a second-year resident in internal medicine. My residency director did allow me to go. I wasn't able to go to Haiti until August 2010, but volunteered at this very small clinic in Cité Soleil, where we provided free primary care to patients. Saw about 200 to 300 patients a day. And this clinic was situated in a large slum where there was a lot of gang activity and a lot of poverty. This experience really moved me because I felt like I was fulfilling Matthew 25, which I will read to you. For I was hungry and you gave me something to eat. I was thirsty and you gave me something to drink. I was a stranger and you invited me in. I needed clothes and you clothed me. I was sick and you looked after me. I was in prison and you came to visit me. Then the righteous will answer him, Lord, when did we see you hungry and feed you, or thirsty and give you something to eat? When did we see a stranger and invite you in, or needing clothes and clothe you? When did we see you ill or in prison and go to visit you? The king will reply, truly I tell you, whatever you did for one of the least of these brothers and sisters of mine, you did for me. At the time, we saw a lot of patients that had hypertension and diabetes, so a lot of chronic disease, including asthma and COPD, in addition to malaria, pneumonia. And I was really struck by the absence of a public health system that allowed patients to access care on a regular basis. Even though we did the best we could to provide free medical care, these patients, unfortunately, weren't able to access a higher level of care, such as secondary care. And this made me think quite a bit about public health. So fast forward to October 2010. I returned to Baltimore to continue residency and was really moved by my experience. I got to care for many individuals who had lost everything from the earthquake, had been experiencing post-traumatic stress disorder, and just really needed somebody to provide compassionate care and wanted to go back because I really felt moved to go back. So I did. I went back in October 2010. And a few days after I arrived, there was a cholera outbreak that was declared. Several cases of acute watery diarrhea were reported in an area called Mirebalais. And soon we started seeing many patients that had cholera come into our clinic. And these individuals were extremely sick, had traveled sometimes for hours, had severe dehydration. And you treat cholera by providing hydration quickly through oral rehydration therapy or IV fluids. Sometimes you give antibiotics such as doxycycline. And patients sometimes become unresponsive due to the degree of dehydration. And when you put an IV in or give them you put an IV and give them IV fluids, they respond quite quickly and are able to actually get up and walk several hours later. It's quite remarkable. Now, cholera is a preventable disease. It's a disease of poverty that's fecal oral in terms of route of transmission. However, it's highly preventable because if you actually provide people with access to water and good hygiene, it's easily preventable. And we would treat patients, send them home, back to the same conditions in which they lived. So lack of water, lack of good hygiene. And again, I was struck by the fact that, number one, the system in which they lived really had an impact on the fact that they were able to get cholera. In addition to that, in terms of health systems, being able to set up a cholera treatment center, fund it, maintain it, required a country to have a good public health system. So these are things that I really mulled upon during my time there. So as I had mentioned, I finished my residency, moved to Haiti, continued to work on these things. I managed a clinic and worked on cholera, and moved back to Baltimore to do my master's in public health. One of the projects I worked on looked at preparedness for cholera outbreaks and how a health facility can prepare for outbreaks. And we did these simulations at multiple health facilities to look at factors such as supply of medicines, human resources, preparedness, training of physicians and nurses, having a contingency plan to respond to a cholera outbreak. And we published on this, but I realized that beyond just providing one-on-one care, public health was really important. And the difference between public health and medicine, they're intertwined, is that public health looks at the health of the population as a whole, as opposed to medicine, which looks at the individual. And in speaking with one of my residency directors, I just thought, what do I do? Do I continue to practice medicine, or do I go into public health? And he said, well, you have the opportunity to either care for patients one-on-one, which is extremely important, or to look at public health as a whole. And I struggled with this throughout my fellowship, and ended up going into public health. And I encourage you to look at public health as an option. I think being a physician, you have a unique skill set. It's probably one of the highest callings that you could have, and you're following in the footsteps of Jesus, who healed anyone that came to him, was moved by compassion and healed. However, I do think that as a public health practitioner, you also get to look at the bigger picture, looking at health systems and looking at how to improve the system that does provide care to individuals, to the least of thee. I'm going to fast forward to 2014. I again deployed with Samaritan's Purse, and this time to Liberia. And this was during the West Africa Ebola outbreak. The West Africa Ebola outbreak was the largest Ebola outbreak historically, and took place from late 2013 to 2016. I was working with Samaritan's Purse at the time, and we were caring for patients in an Ebola treatment center that was quickly overwhelmed with patients as the outbreak spread. So the outbreak was first detected in Guinea in March 2014, though cases of a hemorrhagic fever were actually reported in late December 2013. So the outbreak actually spread quite rapidly because it had been undetected. By March 2014, cases had spread to multiple countries, including Liberia, Sierra Leone, and Guinea primarily, but then again spread to countries like Italy and Senegal, Nigeria, etc. Unfortunately, one of my own colleagues, Dr. Camp Brantley, contracted Ebola, and we had to care for him and care for Nancy, who also was working at the Ebola treatment unit, in addition to all the patients that we were caring for. The World Health Organization declared this outbreak to be a public health emergency of international concern, and both Kent and Nancy were evacuated back to the U.S. This experience really struck me because I started thinking about preparedness. How do we prepare a country to deal with an outbreak? And this was back in 2014. The entire world got involved in this outbreak, and many countries sent volunteers, organizations were activated. There was a lot of funding from different countries to go to West Africa to respond to the West African Ebola outbreak. I returned to Guinea in late 2014, this time with the US government, working as a public health specialist advisor, where we looked at setting up systems such as surveillance systems, ensuring that there isn't enough infection prevention control measures to respond to the outbreak, in addition to things like risk communication. And later on in my career, I ended up working quite extensively on Ebola and on outbreaks, looking at how to build capacity to respond to outbreaks. I've been working in DRC for the past 2 years now with the World Bank. And we have been primarily trying to build the government's capacity to respond to Ebola and other outbreaks. Public health, as I had mentioned, is extremely important because you're looking at systems that are put into place again to help communities deal with multiple disruptions to their health system, such as disease outbreaks. And that's just one example. That's something that I've worked on quite a bit. But there are other things such as chronic disease, non-communicable diseases. So as you look at serving, I would strongly encourage you to look at public health as an option. And through that, you will fulfill Matthew 25 and provide services to those that are sick that Christ has asked us to pay attention to be compassionate about. Thank you so much for your time.